Today's module is on knee meniscal injuries or meniscal tears. It's important to identify these injuries early on, as patients may have significant problems with weight bearing or, for example, return to play. And there are some interventions we can do that will allow the patient to get back to full function earlier if we make an adequate diagnosis. Also, it's encouraging that adequate diagnosis is not very difficult, at least for you to get an estimate within the exam room, understanding that diagnostic confirmation typically involves getting an MRI or an MR arthrogram. This is a model of the knee. The meniscus is this cushioning between the femur and the tibia. It's a way of distributing the pressure from the femur onto the tibial surface. Typically, the medial meniscus is more injured than the lateral meniscus, but again, if you use careful physical exam, you should be able to distinguish between these. When we get to the exam room, I'll show these in more detail. Okay, so for knee meniscal tears, typically there is acute trauma. Sometimes in the older patient, it may be more just an overuse type of thing or something sudden that happened at the gym. But usually in the younger patient, there's something like an acute twisting injury during sports, or, for example, in my population, patients who've hit a dashboard from a motor vehicle crash, that sort of thing. You need to be careful because for older patients, sometimes you see degenerative tears in the meniscus, and that does not necessarily indicate the patient's clinical problem. So once again, we treat patients and not pictures, and that's again why it's so important for you to do a good exam room set of diagnostic maneuvers so that you have, before getting the scan, some idea of what might be going on with your patient. As I like to say, we don't go fishing. You want to go fishing? Go to Alaska. You have to walk out of the exam room with some reasonable idea in your differential diagnosis of what might be going on with your patient. In terms of physical exam, we could probably start this with standing. And one of the best tests I find for meniscal injury is the so-called Thessaly test. And what happens is the patient bends about 20 degrees and they rotate. I'm not using my hand for much weight bearing, just for balance. Typically they do this against the wall. And this rotation often reproduces meniscal pain. So patients, if they have a medial meniscal injury, they'll say, yeah, it hurts here on the inside of the knee when you do this rotation. And then you've, of course, compare it to the other side, which is something we always do. And it would be one clue that they have a meniscal injury. There can be other things that do this, for example, arthritis of the knee. But it's a supportive sign, along with other findings, that help you with your diagnosis. The other thing is, I call it duck walking, but I don't think ducks walk this way. But you have the patients bend the knee like this, and you have them walk like that. And that's actually really hard on the meniscus, and that will typically reproduce their pain as well. Now with the patient supine for the meniscal exam, again, you always start with your lumbar spine and your hip exam. So you just do some brief screening there. Again, what you're looking for is, could this actually be referred pain from the lower back or hip area? Can there be more than one injury? Remember, in trauma, the patient has as many diseases as they pleases. Okay, they could have both a hip injury and a knee injury. Okay, so that's important. It's not hard to just do a little bit of basic testing more proximally to make sure you've been complete with your assessment. I'm going to assume here that Jennifer has a left medial meniscal tear. The way I would start my supine exam, I'd start by first testing for warmth. Okay, so you use the back of your hand. Much more sensitive for some reason than the front of your hand. Be palpating very lightly to see if there's focal warmth in that area. And again, I always start with the good side. Next, I'd be looking for an effusion. And there are a few ways to find an effusion. One, if it's obvious, you'll just see this big ballotable patella. And you can tell this side looks like a grapefruit and that looks like a skinny little orange. But there are more subtle tests usually that are useful. One is the so-called milk test. And this will be a little bit hard to see maybe, but you milk all the fluid up and then you bring your hand down. And if there's an effusion, you'll see a little bubble of fluid coming on the medial side. That's a subtle test. A lot of people are not terribly good at it, but if you keep doing it with your patients, you'll get better and better. The second thing, which is a lot easier, if you're in a you don't do this all day long. You just put the knee into flexion. And if there's an effusion, let's say in the left knee, this I can go all the way into flexion, no pain. But if there's an effusion in the left knee, usually you get to about there and then they say that really hurts. And it's kind of a dull pressure that they feel throughout the knee. So that's a good subtle sign for effusion. Correlate that, for example, with an MRI scan you might get later. Then we're looking for, in the case of meniscal injury, getting to the femoral tibial joint line. So let's say it's a medial meniscal tear. And you can palpate. Here you'll feel the femoral condyle, and then just below that you'll feel the tibial plateau. So you can just palpate along the joint line. And for medial meniscal tears, it's typically focally tender here. You can test if you're on the right track, as you can try above and below, and they're typically not very focally tender. For lateral meniscal tears, not as common, you'll feel it more on the outside. For completeness, you want to also palpate the patella. So sometimes what you can do is relax the knee, and you can get to the underside of the patella by pushing medially on the outside. And I bring that up because, for example, in my population, patients who've had car crashes and their knee hits the dashboard, they might have additional patellar problems, like an osteochondral defect, for example. Sometimes you can even pick up osteochondral defects on the femoral condyle, just above the joint line. For completeness, you should also palpate posteriorly. And a number of meniscal injuries actually affect the posterior horn of the meniscus, so you'll feel tenderness there too. If you suspect a pes anserine bursitis, you can palpate here. But usually that's not as often present as a meniscal tear might be. If there's other conditions such as a lot of arthritis, which we'll talk about in other modules, you'll feel palpable osteophytes, etc., on the joint line. And then treatment is typically physical therapy, sometimes mobilization, including with various chiropractors, but not, that's not common. You might be able to unload the knee, the medial meniscus, for example, if you put a lateral heel wedge in. You'll be focusing on maximizing hip range of motion, strengthening the hip abductors, which seems to help with a lot of knee problems. And I'll show that in a different module for patellofemoral pain syndrome. And in our clinic, if patients aren't getting better, we'll look at PRP injections and then ultimately even surgery. We don't do surgery, but we make the referral. Just remember that in our country, at least, meniscectomy surgery is probably done more than it needs to be. It's just something to keep in mind.